Welcome again, and my name is Merity Sjogren. I am a member of the Perinatal Mental Health Coordination Group with the Mental Health Technology Transfer Center Network. I am pleased to be your host for this session. I am also pleased to introduce this session entitled Awareness and Detection of Perinatal Mental Health Concerns. I would like to thank our wonderful speaker, Dr. Joya Krier-Perry, for being with us today. And a big thanks to all of you for joining in. And we truly hope that you find today's presentation engaging and helpful in your work. Next slide. As always, we need to start with a few housekeeping items. So please know that we have made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up using your registration information. All attendees are muted and cannot share video. If you have a question for the presenter, please enter it into the Q&A pod. If you have a comment or a link for all attendees, then we suggest that you use our chat box. The session recording and slide deck will be posted on our website. And if you attend at least half of the session, you will receive an email following the presentation on how to access a certificate of attendance. This event is captioned. To view captions, click the arrow beside the CC box at the bottom of your screen and choose Show Subtitles. To change the size of the subtitles, click the arrow next to the CC box and choose Subtitle Settings, where you'll find the option of making the subtitles smaller or larger. And if you don't already, we would ask that you would follow us on social media and stay in touch with us. And you can find that information at the bottom of the slide. So next slide, please. We'd like to recognize that participating in this and our other session may activate your own feelings and emotions. As mental health care providers, we also need to care for ourselves. Please monitor yourself and practice good self-care, including taking breaks, stretching, drinking plenty of fluids, and practicing mindfulness, or whatever helps you stay centered and grounded. If needed, we have included some links to helplines and hotlines, and you can see them on the slide here. Next slide. Our SAMHSA-funded Mental Health Technology Transfer Center Network focuses on technology transfer, which means that we have the adoption and implementation of evidence-based practices for mental health across the United States and territories. We develop and disseminate resources and provide free local regional training and technical assistance for mental health workforce. This is a map that displays all of our centers that make up the Mental Health Technology Transfer Center Network. We have 10 regional centers, a National American Indian and Alaska Native Center, a National Hispanic and Latino Center, and a network coordinating office. Please visit our website and find your center so that you may stay up to date on trainings and resources that are offered in your region. Next slide. The MHTTC network recognizes that the language that we use has great significance and may positively or negatively contribute to the health and the well-being of the persons to which we are communicating. We adopt a trauma-informed recovery orientation as an overarching philosophy to guide our work in the mental health field and our language when speaking about people with lived experience of mental health conditions. As an example, our coordination group just learned that there is some discussion in our field right now about the use of the acronym PMAD for perinatal mood and anxiety disorders. We received feedback that PMAD is not preferred by some, and this led us to begin instead using perinatal mental health conditions in our grant work. Next slide. This presentation has been prepared by the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed in the presentation are the views of our speaker and do not reflect the official position of the Department of Health and Human Services or SAMHSA. Next slide. We have an amazing presenter with us today. Dr. Joya Krier-Perry is a thought leader around racism as a root cause of health inequities. Speaker, trainer, advocate, policy expert, and fighter for justice. She is the founder and president of the National Birth Equity Collaborative. Recently, Dr. Creer-Perry addressed the United Nations Office of the High Commissioner for Human Rights to urge a human rights framework to improve maternal mortality. Previously, she served as the executive director of the Birthing Project, director of Women's and Children's Services at Jefferson Community Healthcare Center, and as the director of clinical services for the City of New Orleans Health Department, where she was responsible for 4 facilities that provided healthcare for the homeless, pediatric, WIC, and gynecologic services within the New Orleans Clinical Service area. Dr. Creer-Perry has been celebrated for her work to improve the availability and utilization of affordable healthcare for New Orleans citizens after the Hurricane Katrina disaster of 2005. Currently, her focus has expanded nationally and internationally as it relates to maternal child health. Dr. Creer-Perry, we thank you for being with us today. And at this time, I will send the slides over to you.
Well, thank you so much, Meredith, for that introduction. And I'm so excited to be here with you all. As you know, we have really undervalued the importance of well-being and of mental safety, especially when it comes to perinatal work. So it's amazing and an honor to be here with 300 and something folks who are interested in ensuring that we stop doing that and we work together to ensure that all people have justice and joy. So I am technically not savvy, so I think it's Marianella who's helping me with the slides. Will you go to the next slides, please? So our organization is 6 years old now. It's kind of crazy. Time flies when you're having fun. And we started with really focusing on Black infant mortality, because although I am a Black woman who's almost 50 years old, sitting in a Black woman's body, who's a mother, like many of you, we focus so much on the baby and you throw the wrapper away, right? So the candy is the baby. And once the baby's born, we throw the wrapper away. But really the impact of mom and mamas and birthing people on the lives of babies are so important. And about 6 months into our founding, we added Maternal to our mission and vision. And we're really right now revamping and looking at our vision. The one that will be hot off the press is all Black mamas, babies, and their villages thrive, because we really keep expanding our understanding of what it really takes for us to all be in the future thriving. Next slide, please. So here are our core missions, core objectives for today. We're going to get through these and we're going to all move forward. Next slide, please. So this slide is a little important for me, at least. The reason why it's important is because so often people want us to come in as an organization and give them some rapid scale up how we can fix all these things and ensure that we get away from all this racism stuff and move forward. But what it ignores is that for 86% of the time that we have been, Black Americans have been in the United States of America, it's been under explicit or legal oppression, right? We could be sold, raped, murdered, owned by legally. We could also, even after we were no longer being able to those things, we still couldn't be in the same waiting areas. We couldn't be able to receive the same care. And so although for the last 14% of our time here, we've been legally able to do those things, to hold that wasn't just about laws. It's about a cultural belief and a hierarchy of human value based upon skin color. And when you believe that, that infiltrates your laws and your policies, and also how you treat the patients that you all see and take care of, and how they're treated and seen in society. So this is not going to be fixed with one webinar, one rapid cycle, quick fix. It's going to require all of us to invest in long-term commitment to unlearning the harmful things we all were taught and building a community of solidarity and unity going forward. Next slide, please. So as was mentioned, I've been able to present at the UN now twice. The first time they flew me to Geneva, it was 2016 and pre-COVID, and I got to be in this room where people had little things in their ears, listening to my my words in different languages. It's pretty exciting. And recently I did it again through Zoom. So like this, we're all learning new ways to communicate. But as a Black woman, going to Geneva was really humbling, deeply humbling, because we never think about what does a human rights framework mean, right? The United States, as I mentioned, Black people were considered to be 2/3 human in our original founding documents. We fight for civil rights in this country. The white women had to have permission of their husbands to buy birth control in 1965. So not only did you have to have permission, but you had to be married to even get the permission, because you weren't seen as fully human and capable of having all the capacity to make decisions on your own. Every other high income country, everyone that has, all of them have better birth outcomes than we do. mental health outcomes than we do. And all of them believe that all people, just by virtue of them being born, have the capacity to thrive. So their job is not to decide who has value and who is deserving of rights to be married or rights to vote or rights to be able to get access to health. They believe just your birth means that you are have human rights. So what would it look like if the United States really operationalized a human rights standard? That's the global standard for every other wealthy nation that says all people would be able to thrive. And we are the most diverse, right? So what would it look like for a diverse nation when it comes to religion, to ethnicity, to geography, to gender, would invest in all people being able to thrive? Next slide, please. About 26 years ago now, there was an election going on like we had recently, and there was a lot of conversation about reproductive rights, right? So reproductive health is what we provide as OBGYN. So as an OBGYN, we do things like pap smears, hysterectomies, abortion, contraception. So that's reproductive health care services. Reproductive rights are the laws and policies that dictate how we get to do that. So things like where we get to teach sex ed, who invest in perinatal well-being and support. How do we make sure that people have access to community resources, right? So those are the rights and the laws. Well, we know, especially as I mentioned, there was a right to own and to murder and rape us. So having laws doesn't mean that you have justice. And so for Black mothers, we worry about outliving our children, right? I have a 10-year-old son, and I don't allow him to play outside with a toy gun because I worry that someone will see him as an adult and shoot him like Tamir Rice's mother had to worry about her child, right? So for Black mothers, we really want to have reproductive justice. And that says the tenets are, we have the human right to personal bodily autonomy. So that means if we don't want a LARC or an IUD, that's our bodily autonomy, that's our choice. If we refuse a C-section, that's our bodily choice. This is our ability to make choices for ourselves, to have children. I personally have 3 children. And when they're all here at my house, which they will be this weekend for Mother's Day, I feel like the little old lady who lived in a shoe, right? I feel like, how did I get all these kids? Where did they come from, right? But people have 8, 10 kids and they are quite happy and successful. It's not my job to dictate how many children people should have. They can have as many children as they would like, or to not have children. I'll pick on my own home state of Louisiana is, again, up until we did Medicaid expansion, just to qualify for Medicaid, which is insurance, just to qualify, you had to have been a childbearing adult. So that means you weren't even valuable enough to receive insurance, no matter how much you worked, unless you'd actually utilize your uterus to birth a baby. So that means nobody who didn't have a uterus would ever get Medicaid, no matter how much he worked and how poor he was. And women who didn't choose to give birth, who were childless by choice or not, still couldn't qualify for health insurance. What kind of judgment is that about how we value human beings and their bodies? And this last one is really, especially in this moment with the murder of George Floyd and Breonna Taylor and Maisha Hall, it's important for us to really think about how we can parent our children in safe and sustainable communities. So that trauma of living in places that are over-policed, that trauma and living in places that are not invested in, that causes us to have poor birth outcomes. So that means that if we show up to your marches around mental health, we need you to show up for our marches around mass incarceration, because our mental health is actually impacted by mass incarceration. And that's our ability to thrive until we get rid of all those systems of oppression. Next slide, please. So when we started our organization 6 years ago, there was not a definition for birth equity. There were definitions for equity, for health equity, but not birth equity. So we looked at all our mission and our vision and our values and the other definitions and say, okay, well, what is in line with our value system to ensure that we have birth equity? A lot of the other definitions for equity talk about it as this place. We're going to get to this place. Everybody's going to be equal. We're going to hold hands, sing Kumbaya, and skip into the sunset. Well, we recognize, especially in our current political environment, that sometimes you get a few steps forward, 5, 6 steps back again. There's a jerk and a start, right? Jumps and starts. So it's not that we're going to get to this magical place and never have to think about it again. Our job is to put the conditions in place, the assurances, the policies, big P, like Medicaid expansion, or the policies, little p, like what are your office hours? How are you treating the patients when they come to your office? Are you going to them? for the conditions of optimal birth. So we don't want people just to survive a birthing experience and say, oh, thank God I made it out of there intact. We want them to thrive, to live their best lives. How do we invest in well-being and fullness? And that means for all people. So we have to be willing to address both racial and social inequities in a sustained effort. Once again, this is not going to be a quick fix. It's going to require all of us to put forth effort for a long time. The same people who are today hoarding power and wealth are teaching their grandchildren to hoard power and wealth. So our job is to teach our grandchildren to fight for justice and joy, because we believe that all people should be in the future. Next slide, please. So you all are really smart people who are doing amazing work around mental well-being, and you probably do a lot of measurements. You're measuring things like how many times a person comes in to be seen, or what their scores on their risk assessments are. So you have to think, where do those measurements come from? Who decided those were the right things to measure? What is that indicator? It's a measurement that's limited by our current reality. It's a product of our past understanding of public health and science and systems, including our invested in mental health care system in this country, are more apt to adhere to specific prescribed indicators than to determine alternatives. So I'll give you an example. Marital status. We love measuring marital status, right? Single Black female. That's the downfall of all of society. If we would just get married, all other things would just be perfect. We just need to be married, right? So the truth is the data does not support that. I married, love my husband, he's super cute, but me marrying him did nothing for my mental and physical health. Me being partner, you can be married and be in a horrible relationship. The act of marriage in and of itself is not what makes people have ability to have well-being. And the other important thing to think about is there are people who can really, for whom, marriage is a proxy for wealth, right? So if my husband had come with a dowry, and when I got married, him and increased my access to capital, then maybe that would be some indicator that we should be measuring. But why do we keep measuring marital status as if the act of marriage is the thing that's going to make us have mental and physical well-being? So then you have to question, under what framework do we pick these indicators like pregnancy intention, right? I intend to run a marathon. We want people to have middle-class intentions without investing in them having middle-class money, right? So why do we pick these indicators? Well, we have to think about under what framework they were picked. A framework could be a vision and expanding our current understanding of current reality. It allows us to explore new language. We don't have to keep asking people about marital status. We can think about what are we asking for, right? Social connectedness and safety. We can explore alternatives to traditional data collection, but we must all of us, question our historical construction of our health system. I would imagine that every person here who works on mental health knows clearly our health system was constructed incorrectly to leave mental health out of everything, out of how we finance, of how we orchestrate, how we put things together. So it's really important for us to think about why would that be? Under what framework did we create that? Both human rights, reproductive justice, and birth equity are all three frameworks under which, when you pick indicators, you can say, does this fit into this framework, right? Asking someone's marital status, does that fit into a human rights framework? Does that believe all people can thrive? Asking pregnancy intention, does that fit into a reproductive justice framework, right? Your intentions, how does that matter when it comes to justice and joy? Next slide, please. So then we have to look at the root causes as to why we keep picking these indicators. How do we get here with these poor outcomes when it comes to mental health, perinatal health, and what can we do to undo that? What are the root causes of these inequities? Next slide, please. So we get hired a lot to do implicit bias training, and this is way in y'all's field and way out of mine as an OBGYN. Dr. Devine is a psychologist, and she sent me all her stuff, all her trainings. Back in 1989, she really started this conversation in healthcare around bias, and this is her definition. Bias is the implicit aspect of prejudice, the unconscious activation of prejudiced notions of race, gender, ethnicity, age, and other stereotypes that influence, this is the part that matters, they influence our judgment and decision-making capacity. We all have biases. We need to know the difference between a wild animal and a cat. When you walk outside, it's like, is that a cat, a house pet, or is that a mountain lion, right? You need to know that without thinking. It needs to be subconscious and fast. What we don't need are biases around individuals like race, gender, age, obesity. Those are the biases that have been baked in, that our judgment and our decision-making as providers actually causes harm to our patients. So our choices of activating these notions without undoing those harms actually cause poor outcomes for our patients. Next slide, please. So bias is inherent, and they skew your understanding and unintentionally affect your actions and judgments. So the first thing to do is understand that it's unintentional, and then focus on mindfulness. I'm sure y'all are all doing mindfulness, but stop and be still and really think, these are the biases that naturally come up for me, right? So how can I be mindful and move forward and not react without seeing the person as fully human and being able to thrive in the future? Next slide, please. So these are some reflexive critical thinking that you can do after you've taken the Harvard Implicit Association test or whomever, some other implicit bias test, and seen where you are with your biases. We all think of ourselves as objective and fair, but critical thinking becomes moot when you have sexist, racist, or anti-science views. And beliefs and values are normative because they're linked to powerful social institutions that we trust. My daughter went to high school at the same high school that our latest Supreme Court justice went to in New Orleans. She grew up in New Orleans. And this is a Catholic high school, and they were teaching in class that birth control pills cause breast cancer. So of course she's my child, so she raised her hand and got into an argument with the teacher. But if your high school that you love and it's a great school is teaching you this, you're going to really believe that information. This institution that you trust. It's going to be hard to let go of those notions that were not anti-science and were never true in the first place. And when you don't know what information to trust and you have weak commitments to new ideas, then research shows that you're less likely to take action. So that's the whole, I see the world as gray. I don't really know what to trust, so I'll just be still. For when you're talking about racism, if you are still and don't fight with us, then you're also harming us and yourself and your future children, future family. So really important for us to not just seek out alternative explanations to say, oh, the reason we have poor birth outcomes for Black people is because they just make bad choices. That's been the narrative for a long time, and that narrative has never been true. Next slide, please. So what we can do is work on stereotype replacement. These are some of the strategies that she's shown within 2 hours. She can help decrease bias in others. We do about a 4-hour training because we include structural aspects and not only just individual biases, but how that's tied to structures. For stereotype replacement, if you do a test and see where your stereotypes are, you can think of counter stereotypes. Individualize instead of generalize, and really taking the time to lean in, to spend some time with communities that you have not, to walk in others' shoes. Segregation was an effective tool that caused harm for all of us, so we don't know each other as communities. We've not spent time together. All we know about each other are things that we see on TV. So it's important to spend some time walking in each other's shoes. Next slide, please.
Next slide, please.
Okay, so back in 2005, I was a director of clinical services for the City of New Orleans Health Department. So we all know what was happening in 2005, right? The president flew by and waved at us. But the World Health Organization actually came to town. They came and sat in a hotel room, and they were talking about this because all the buildings were flooded, so the hotels was what was available. And I was a young person in the room taking notes as they were talking about this idea that it wasn't just your genes or your choices that cause poor birth outcomes or health outcomes, but these other things called social determinants of health. Things like having safe and affordable housing, a living wage, availability of food, jobs, like that impacts your health. Can you push it again, please? And that causes unhealthy behaviors. And push it again. And that's what causes a disparity in the distribution of disease, illness, and well-being, right? So it's not that we have higher rates of childhood obesity just because children like Chewies. I mean, I like Chewies, right? It's not just a choice or their genes. It's because we don't provide physical education in schools, because we don't have healthy diets, because we don't have places for them to play outside that are safe and sustainable, right? So these are policy choices, not individual behaviors or the genetics of children making childhood obesity increase. But you see the top of my slide is still empty, because although it's exciting that for the last 16 years, we've been talking about this idea of social determinants of health, what we haven't talked about is where they come from. What are the root causes of these social determinants of health? I've always lived in Black neighborhoods, not because it's tribal and I just see Black people and I think, oh, I want to live there, right? We know there's a history of redlining, of neighborhood covenants that created segregation that caused that. So what are the root causes of these social determinants of health inequities. Can you push it again, please? And that's because we have a power and wealth imbalance. Push it again. Push it one more time. And those are things like our labor markets, our housing policy, our education system, our social safety net, which we don't invest in this country, our tax policy, and that causes our social determinants of health. Push it again, please. In the US, they have three main root causes, push it again, which are racism, classism, and gender oppression. You could add some more, especially for my home state of Louisiana. You could add religious fundamentalism. If you're in another context, you might add casteism, you might add tribalism. Push it one more time. But if we do not undo the social determinants, the root causes, we will just be creating strategies and policies around those social determinants of health, and we'll never see the gaps close in this country, and we'll never see the well-being and the justice and joy that we all deserve. So what that means practically is we now finally realize that transportation impacts health. So what do? We give clients Uber and Lyft vouchers, and we say, hey, we want to make sure you make it to this appointment. Here's a Uber and Lyft voucher. What we haven't done is undone the segregation and the redlining that causes us to not have a real transportation system in this country. Every other high-income country has trains, they have buses, they have free access. We had the Green Book, and we had people of color that had to figure out where the sundowner towns are. So that history and legacy of racism is deeply embedded in even the fact that from rural to suburban to urban America, we have a poor transportation infrastructure. So how do we fight for that? How do we ensure that we're supposed to have free access to transportation as a right? Next slide, please. So the social determinants of health are the conditions in which people are born, grow, live, work, and age. Everybody, if you're in public health or healthcare, most of us can quote that first sentence. It's been around since 2006. But what we haven't been able to do is talk about the second sentence. It's like the Constitution, or in my world, the Negro National Anthem. We can say that first verse, but when you get to the second verse, people start mumbling a little bit, right? So the second sentence, though, is so important. It's where the money resides. These circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. So as you're doing your work and ensuring that people have perinatal mental health, if we don't understand that how these circumstances, their circumstances, are shaped by the distribution of money, power, and resources, you're going to be wading in water and only frustrating your clients and your patients and yourself, and talking about individual responsibility and bootstrapping when they're trying to figure out how they're going to pay their bills because we have not invested in a minimum wage that's a livable minimum wage in this country. Those are policy choices that are determining people's health. Next slide, please. And racism affects our body both directly. I mentioned worrying about my son playing outside. So that means if I'm worried, my heart's racing, my catecholamines, my adrenaline's up, right? So that has a direct biological effect on your telomeres. So we have higher rates of hypertension, diabetes, obesity, not because we're just born genetically inferior, but because the harm of racism on our bodies causes us to stay in fight or flight at all times. And your body can't tolerate always being nervous, always being revved up, always waiting for not just a microaggression, an actual aggression all the time. And then also indirectly through race-based discrimination across schooling, safe neighborhoods, and good jobs. So both ways. Next slide, please. So race does not equal an ethnic group. It does not equal a population. It does not even equal ancestry, right? My daughter did the 23andMe thing. I refused, but she did. So I'm going to assume I have at least half of what she has. So we're as equal Nigerian as we are Irish. So to decide that my Blackness or any kind of illness that I have just comes from my Nigerian ancestry makes absolutely no sense. I didn't get anything from the Irish side, right? This idea that you can look at my skin color and dictate and determine my risk for things like diabetes or my pelvic shape or my kidney size was always racist. It was never a biological truth. Medicine and public health were colonized by white supremacy to make up these things that make no sense. I'm from Louisiana. You could have two sisters, one marry a white man, one marry a black man. One raised their family as white, one raised them as black. They didn't change their genes. That's just the social construction. Race is a social and political construct. We completed the entire Human Genome Project. There is no biological basis for race. There's no Caucasian race. There's a war going around right now in the Caucasus Mountains, and it has nothing to do with white supremacy or white people, right? So this idea that there was a biological basis of race was always flawed. And it's a 400-year idea that we need to let go, like the earth was flat. So race is real, and it matters in society, but not how racists think it does. Race is not biology, but racism, the harm from you believing that I'm broken, causes me to have biological harm because of the way you treat me, the way that what happens to me when I show up in spaces, that actually has an impact, not just innately who I am as a human being, because social constructs are real for those who hold them. Next slide, please. So it's racism, not race, that causes health inequities. You know, when we talk about lung cancer, for example, we don't say that it's the smokers that cause lung cancer. We say it's the cigarettes. And we work really hard to tax the cigarettes, to explain to people the harm of the cigarettes. We don't say it's just too hard. People are just going to be addicted to smoking forever. So we're just going to have to, it's just the smokers. They're just bad people. They must be broken. They just keep getting this smoking. We actually work really hard to undo that. That's what we're going to have to do when it comes to racism. We're going to have to name it, see how it's operationalizing in systems, and then hold it accountable and end it, the devaluation of human bodies based upon skin color. Next slide, please. So that means we have to have a common understanding of what racism means. When I first started doing this work 6 years ago, when I would say the word racism, people would get so nervous. They would think I was calling them a bad name or a bad word or some kind of judgment. And I always, at the beginning, I never could understand why they were nervous about me saying the word racism, because I'm the one that's actually impacted as a person of color. But it's interesting to think about how it became to mean for people a bad, mean-spirited person. But it's been a norm. It's been in our textbooks. It's been in our policies. It's the belief that some people, based upon the color of their skin, should not have. And therefore, we made policies around that. So we're going to go through these definitions that are created by Dr. Kamara Jones that are in public health, because we need to understand the different levels of racism so that we can then see how they're operationalized and what we must do together as in collectively, but also as individuals to be anti-racist. Next slide, please. So the first level is institutionalized. And those are the structures, policies, practices, and norms resulting in differential access to the goods, services, and opportunities of societies by race. So I'll give you a clear example in the field of healthcare. So back in 1965, when we were creating Medicare and Medicaid as a nation, as a social safety net for health for people, we were in a very different space as a country, right? So the country had been legally segregated for many years. And so this idea for Southern senators to give health coverage to people who were poor, who they presumed to be Black or brown, they said, oh, we got to control that. That cannot be something that's just the federal government just gives them. We don't know if they deserve to have health, right? So Medicaid became a state's program run by states. Medicare, which one gets after you've retired, so that with the procedure after 30 years. So the perception is that's white people, so much so that the original Medicare program excluded farmers and homemakers. In 1965, who were the predominant farmers and homemakers? Black people. So we created a law around who had access to health insurance and health coverage. This continues that strategy today. So when you think about Medicaid expansion, you look at the states who refuse to expand. They tend to be states that have more Black and brown people. Also tend to be states that desire to have more restrictions on bodily autonomy. So that institutionalized racism still holds today. And they'll make rules like they tried to in Michigan that if you live in urban Michigan to qualify for Medicaid under expansion, you must work. And if you lived in rural Michigan, you don't have to have a job. Once again, racializing that Black folks in Detroit, they don't deserve to have health insurance unless they're working somewhere, right? This is racism. Personally mediated is what you think of when I say the word racism. And that's the biases and differential assumptions about the abilities, motives, and intentions of others by race. That's the tiki torch. I called you a bad name. You're being mean to me. That does happen. It happens in some of your institutions and some of your spaces. It's not the overarching reason why we have health inequities in this country and in this world, but it does still happen. It's something we need to hold accountable. And internalize is really important, especially for Black folks. We've known about this for a long time. If you live in a place, in a world that devalues you, you start devaluing yourself. The acceptance and entitlement of negative messages by the stigmatized and non-stigmatized group. So imagine if you are told over and over and over again that you're broken because of your skin color, you do things like try to lighten your skin or straighten your hair or not live near other Black people, or and all these are because we've been devalued. But also for the non-stigmatized group or for white folks, imagine what it means if you believe that you're supposed to have things just because of whiteness, right? So then you do things like vote against Obamacare, even though there's a huge need for mental well-being in your community and people need access to coverage. But if you think of that as supposed to be some Black people thing, then you're voting against your own self-interest. That's articulated really well with my colleague, Dr. Jonathan Metzl, in Dying of Whiteness. If you have not read that book, it's a great book. Next slide, please. So how does that show up for maternal health? How does this all matter, especially in the context of our mental health is really impacted by racism and by maternal health? Next slide, please. We did a birth equity index. What we did was look at the 50 different social determinants of health to see which ones had positive predictive values for Black infant mortality. Push it again, please. These are the 100 cities that have the most Black births. Some of the things that had positive predictive value you would guess, like smoking and obesity, but some of them you might not guess, or you all probably would, because of your mental health professionals. The number of poor physical and mental health days experienced by residents actually impacts your infant mortality rate. So when we go work with public health departments and they talk about safe sleep, giving out cribs, we say, another thing you could do though to improve birth outcomes, especially improve infant mortality, is improve the mental health of the people in your community, not just the mamas, the entire community. The status of the community actually matters for each individual baby. Next slide, please. So maternal mortality is the death of a woman while pregnant or within 1 year of the end of pregnancy, regardless of the outcome, duration, or site of the pregnancy. 2/3 of pregnancy-related deaths are preventable. The leading causes are cardiovascular conditions, infection, or hemorrhage. For non-Hispanic Black birthing people, hypertensive disorders, preeclampsia and eclampsia, and cardiovascular diseases such as having an enlarged heart or cardiomyopathy. Next slide, please. We see that for Black birthing people, our rates are 3 to 4 times or 2 to 3 times, depending on which data you look at, higher than our white counterparts. In places like New York City, it's 8 to 12 times more likely to die versus say a Texas where the gap is closer. And that's not because Black folks are doing so much better in Texas. That's because so many white women in Texas are dying who would not die if they lived somewhere else that actually did things like invest in Medicaid expansion, perinatal mood support. The places where we have high rates of poor birth outcomes impact both Black and white people and Hispanic people, everybody. It's just that Black folks get the brunt, but we are not the worst in the world when it comes to maternal health just because Black women are dying. There are a lot of other people who are dying because we have not invested in an infrastructure of well-being and wellness in this country. Next slide, please. So when you come to me as an OBGYN or my colleagues, and you ask, what are my risk factors? What should I be worried about? We say things like eclampsia or high blood pressure plus seizure, having that cardiac disease, having your kidneys to fail, your weight, having chronic conditions, having had heart failure. But we don't talk to you about your social risk factors, right? Like neighborhood safety, air quality. We have a lot of information about climate change and how that's impacting birth outcomes, food insecurity, having rigid scheduling. We tell patients they must come in, if they're high risk, twice a week at times. If they have a job where they have no paid leave, they have no office, no hours off, how would they have to choose between feeding their family and coming into an appointment? And if they don't show up, then we blame and shame them for being non-compliant without really thinking about what is their options? What could they do? What could they do in order to be able to support a family and be healthy? Next slide, please. So this impacts of stress on maternal health are so real, right? Thinking about having that rigid schedule, having unemployment, having access to food insecurity. Next slide, please. So weathering is a concept that Arlene Jerome has had around for a good 20 years. And it shows that although we might be Black don't crack on the outside, on the inside, we'll have higher rates of illness and disease because Black people experience early health deterioration as a consequence of the cumulative impact of related experience with social and economic adversity and political marginalization. This leads to premature biological aging and poor health. And exposure to chronic stress causes Black women's bodies internally to age faster, making pregnancy riskier at an earlier age. Next slide, please. And what's going on today? We think about the pandemic and what's happening. Black Americans are disproportionately dying from COVID-19. COVID-19 has overwhelmingly impacted Black maternal health, restricting patients from seeking prenatal care and postnatal care due to concerns or fear of exposure, not being able to have a support person in with you, a partner or a doula during labor and delivery. And then the police violence, this fight around George Floyd and others, constantly there's a new name. It's hard to even keep up at times. Black people are disproportionately impacted by police violence. The trauma of police violence creates stress and adds to that allostatic load, that heart pounding that I mentioned, the adrenaline going, and weathering, contributing to Black maternal mortality. A 2016 study found police killings of unarmed Black people substantially decreased the birth weight and gestational age of Black infants residing nearby. And there's an immediate and long-range trauma from police brutality causes, and it's deadly. Next slide, please. So we know that it impacts our telomeres, that telomeres are shortened when you have maternal stress during pregnancy. And you have, this is data that was done out of, in neuropsychology. So it's really thinking about how the biological harms, how our bodies embody and are impacted by racism. Next slide, please. We also know that 58 healthy premenopausal mothers and caregivers were shown that they had shorter, that was the study that we just looked at. They said shorter mother's telomere length, it was lower the telomerase activity and greater oxidative stress. And this happened when you have perceived stress at all three levels. You have cellular changes from the stress inside of your body. So your ability to ensure that people have mental well-being and to help safety and protection as much as you can and social connectedness actually improves our maternal and infant health outcomes. You have a great opportunity to help us build out a strategy for ensuring that we have better birth outcomes in this country by ensuring that we have mental well-being. Next slide, please. So let's talk a little bit about perinatal mental health. Next slide, please. So chronic stress leads to anxiety and depression. Mental health is a leading cause of pregnancy-related maternal mortality. Untreated mental health issues can cause adverse birth outcomes like preterm birth and lower birth weight babies. Next slide, please. Perinatal depression, up to 20% of women experience a perinatal mental health issue, with 2 times that rate for Black women. New mothers of color have rates of postpartum depression close to 38%, compared with 13 to 19% for all new mothers. A recent study found that the mothers who perceive that they have been discriminated against are twice as likely to skip their postpartum visit with clinicians. And we know that about 1/3 of people who die within a year of childbirth die in that postpartum period after that 6 weeks check or after they've gone home. So if we're skipping that postpartum visit, we're missing the opportunity to see all these other things that are happening and to ensure that they're healthy going forward. Next slide, please. And so here are some of the symptoms of perinatal depression: sadness, anxiousness, loss of appetite or overeating, showing too much or not enough concern for the baby, loss of pleasure and interest in things, hopelessness, cannot sleep. And so often for my colleagues as OBGYNs, we only see the patient once if they had a vaginal delivery and it's at 6 weeks, and so much can happen between the birth of the baby and that 6-week visit. And we've asked to add another visit at 3 weeks, but they haven't figured out a way to operationalize that. ACOG has recommended a second visit in the postpartum visit. And we need to work with our perinatal mental health colleagues to figure out what is our role, what should we be doing? Next slide, please. Sorry, I was kind of distracted. So birth trauma. This happens a lot, especially for Black, Brown, and Indigenous folks whose birthing experience has been devalued, right? I talked about that earlier. So if you're not supposed to have children, when you show up to have a baby, there's a lot of traumatic experiences. Also, people come with trauma. They come with trauma from either being abused in the past, or there's a lot of other things that happen. So a mother's experienced distress during and after the childbirth. It leads to postpartum post-traumatic stress disorder. Some of the risk factors for birth trauma are not having informed consent. So many patients talk about things were done to them without someone asking their permission. Lack of support, being able to have perinatal support, especially during COVID, that's even heightened. Feeling ignored, powerless, being disrespected, having a C-section has been or a surgical birth, and then just negative birthing experience in general. Next slide, please. When life was hard, there was no luxury to wallow. It's kind of a Black woman's thing to say, right? I don't have time to be tired. I can't be tired. I ain't got time for that. I've said that many, many times, right? So Black women are impacted more by risk factors and at higher risk for perinatal mental health issues. Chronic stress is a risk factor, and so are those social determinants of health that I mentioned. So despite those two things, though, Black women are less likely to receive quality and adequate mental health care. But you all are going to fix that. I have a feeling. I'm excited about it. Next slide, please. Here are some of the barriers: stigma around mental illness, the screening and general access to care, limited access to healthcare services, disconnection from providers, lack of access to providers that look like them, unavailability of culturally and linguistically appropriate services, indestructible Black superwoman narrative, right? I ain't got time to be tired, I'm superwoman. Accepting depression diagnosis is viewed as being an unfit mother, right? So the stigma of even the title. And then here's a big one for our community. Criminalization of mental health disorders for Black women increases worry about losing custody of children. So it's a vicious cycle. You don't want to explain that you're feeling depressed or anxious because they're going to call child services or someone, and then you're going to lose your baby, but then you might because you feel depressed and anxious, right? So how do we really reimagine the criminalization, the hypervigilance around people of color, mothers of color? Next slide, please. So what are some strategies? I'm not all doom and gloom. What can we do differently? Next slide, please. What's missing from the care of Black women is their centered voice, validation of experience, and freedom to choose and be informed. Black women need respectful care that is free of implicit and explicit bias. It is the provider's responsibility to address those biases. To address this issue of maternal mortality, we need care that originates from and is defined by Black women-led organizations, practitioners, and community members. Next slide, please. We have the Moms Act of 2021, which is part of the Momnibus. It's super exciting. It calls for financial investments to increase the number of Black and Brown clinicians providing maternal mental health services and community-based maternal mental health support. Our goal is to establish a maternal mental and behavioral health task force and work to improve maternal mental and behavioral health outcomes with an emphasis on the outcomes for minority women. Next slide. You can have a racial equity lens, knowing that your system, the system around mental health alone, is not equipped to overcome inequities driven by income, language, education, or racism. So really centering the place and looking at the aggravated risk and addressing intergenerational and cumulative effects of structural racism on health. Next slide, please. You can do a racial equity analysis asking what, why care, and now what? A root cause analysis around racism. So some of you might do these in your institutions around things like you didn't give a patient medicine or a person missed their appointment, but really looking at the devaluation of patients and what's the root cause of that and how do we undo that? And then the 5 whys, really identifying an event, identify tangible structures that you can do to improve it, and then brainstorm for actions on how to move forward. Next slide, please. We are part of the Global Respectful Maternity Care. We have some funding through the Robert Wood Johnson Foundation to socialize and create a patient experience around respectful maternity care in the United States. Next slide, please. These are some of the things we interviewed Black birthing people around. What would respectful maternity care mean to them? Some of the things you would expect, like empathy. They want someone to actually empathize with them, and racism. But trust is a big one. We talk a lot. You hear trust mentioned a lot, especially right now when it comes to the vaccines, that people trust the vaccine. Do you trust your patients? Patients want us to trust them, that they are good historians. When you write down the word poor historian, or when you write down the words non-compliant, what are you saying about your level of trust in the patient and their wants and desires? So what does a future look like where we actually trust our patients and believe that they want what's best for themselves? Next slide, please. These are the cities where we interviewed Black birthing people. Next slide, please. This is our cycle to respectful care that was just accepted for publication. Yay, that was a lot of work. It's a cycle and not just a hierarchy and a pyramid, because you're not going to ever be totally complete. It's not cultural competency, it's cultural humility, humbly, always lifelong learning about others' communities and other systems. So the first step for the cycle to respectful care is waking up. And that might be that you watched the murder of George Floyd, or it might be that your boss at your job, or you are the boss of the job, and you say, you know what, we looked at our data and we think we need to ensure that our outcomes for people of color are improved, so we're going to wake up. So our first step is getting ready. That means internally ready, yourselves, challenging the things that you were taught, gain insights, read books, unlearn the harmful belief in a hierarchy of human value based upon skin color, gender, age. After you've worked on yourself, then you work with others. Then you create change in the community. Don't jump out tomorrow and say, I'm going to go change the community if you have not unlearned the harmful things and the harmful ways that we interact ourselves. Next slide, please. And this is my last slide. My favorite book is Ibram Kendi's Stamped from the Beginning, The History of Racist Ideas in America. He leads the Anti-Racism Institute at Boston University. And people often ask him what came first, racist ideas or racist people? And he would say, you know, people use racist ideas to hoard money, power. And in this book, he follows several people, and one of them is Abraham Lincoln. As a Black American who's at least 7 generations in this country, you know, you got to love Abraham Lincoln. Free the slaves, yes, but he's a complicated individual. So imagine it's near the end of his presidency, and the 5 Black folks come to this White House and say, hey, we're excited. We're winning. What's happening? And he says, hey, guys, I have a few $1 million. Liberia says you can come back, take your people and go, or you can go to Panama. I don't know, a Black or brown place, but either way, we need y'all to leave. And he says to them, and when the Black folks say, you know, we've been here for 250 years, building all this for free. We think we're going to stay. And his response is what's so critical, especially for all of us as we work together. He says to them, but guys, you're being so selfish. If you would just leave, the war would end and we can move about having our nice country here with white folks. Because the truth is, although Abraham Lincoln was a good and moral man who believed slavery was bad, he also believed Black people were broken and that we had served our purpose in building the country and we need to go back to a Black or brown place. So if you are in this work and you believe your job is to save Black folks, people of color, because they're broken, we don't need you to in this work. We need you to understand that there's nothing broken about us, that systems and policies have been trying to break us. It's amazing that we're even still here and we're resilient and we're all the same. To be actively anti-racist is to know that we're all in this together for justice and joy. Thank you. Next slide.
Okay, thank you so much, Dr. Kerr-Perry. We appreciate you sharing your expertise, and we would like to take some time to answer some of the questions in our Q&A pod. So I'll go ahead and try to pull those up. I also have a little struggle with text, so give me a second here. I'm going to try to in summary with our first question is from a new graduate who is a psych mental health nurse practitioner, and she's interested really in women's mental health, specifically that perinatal postpartum mental health. And her question is really surrounding our interprofessional collaboration and her efforts of trying to find a collaborating psychiatrist in her area. And she's noticing that there's some personal aversion to prescribing medications to treat perinatal depression for women in this particular period. And do you have any suggestions for combating this type of a barrier when approaching potential physician collaborators? So working with this idea of should we or should we not prescribe?
Yeah, you know, the hard part is many of us are not comfortable with prescribing because we just don't learn enough about the different indications for the medications. We don't learn enough about the side effects, and we don't feel comfortable doing it. The assumption that OBGYNs are comfortable with prescribing medications is a flaw in our ability in our training, truthfully. And so working with the provider to provide them with information about potential side effects or some reasons or even some data. I would love when patients, I was open to that, not all providers are, but I knew that there were some things that we did not learn everything in a training, right? So there are many things we can learn from our nutrition colleagues, from our mental health colleagues. There's so much out there besides what we learn in the interactions of an OBGYN residency. So really, if I would try to provide with information about the medications to help assuage their fears and their concerns in a way that is not threatening, and you know, that's really just here to try to help support the patients and give the provider more information.
Yes, that is an excellent suggestion. And I would like to tack on to that too, that we need to remember our breastfeeding colleagues, our experts in breastfeeding, because we run into that too sometimes. Next question. Could perinatal depression and anxiety also affect moms who adopt an infant child, or would this fall more under depression and anxiety without that perinatal period?
Yeah, so we believe all mamas are mamas. So if you birth the baby out of your, the biological impact is the same. So perinatal, if you've adopted, you're still a mama, and you can be depressed, you can be anxious. There's still all the other social factors that we talked about earlier still exist. And so it's important for us to not deny adoptive mothers of their participation in being a mama.
Okay. This one looks pretty straightforward. Where will the cycle to respectful care be published?
Oh, thank you for asking. I should know that. The internet. IJ. I know the acronym. I will. I'll send it to you after and you can share it with the group. It was just accepted like 2 days ago.
Okay, still brand new. So yes, we will be able to have that. Okay.
Thanks.
So here's a question. Could you share the relationship between racism, the perception of pain, and birthing mental health?
Ooh, that's a good one. Well, I tried to talk a little bit about it when I mentioned this history of J. Marion Sims, because we can't extract kind of how we get to the racism without understanding our history. And people want us to just jump to, well, how do we get here today? But this idea that the founding person in gynecology created books and lectures that said Black people did not feel pain. But one of his reasons for saying that is because he could not get any white patients to finish the surgeries that he could get the Black women who are enslaved to complete. He missed the part that they were enslaved, so their ability to say no was very different from a person who was not enslaved. So that leads to current day thinking today that if we don't feel pain as much, we are then less likely to be then treated for our pain. And so then that's going to make us be anxious and nervous, right? Because if we have data that shows if you have a C-section and you're not going to have your pain addressed, you're so nervous about going home with this new baby and not having access to pain. And so anxiety is really high. So all of that is so deeply tied. You cannot separate one of those moments from the other.
Thank you. Okay, next question. How amplified is this for teen mothers of color? How can we better support young mothers at the middle school or high school level who are already uncomfortable with mental health?
Yeah, it's really important. I think we're doing a much better job of not stigmatizing young parents and young birthing people because that wasn't working. The blame and shame of any group. It doesn't matter if you're a young mom or if you're whomever, nobody likes to be blamed and shamed, right? And so really supporting and finding room for mental health. And the other, it's a policy issue too. We don't allow for mental health care services in schools. A lot of times birthing people, teen parents are taken out of schools or the situations where they would have this kind of support where if they do have mental health services in a school, many times birthing people are taken away from that. So we have to create a policy fix that says we're going to support people where they are and we're going to ensure that they have the things that they need to thrive.
So another, I think, easier question. What was the name of the last book that you referred to? They didn't catch the title of the book.
Stamped from the beginning, like you stamp because it's a statement that Thomas Jefferson made, I think. I don't want to misquote, which a famous president said that Black people were stamped from, our darkness made us stamped from the beginning to not be able to thrive. And so that's the name of the book, Stamped from the Beginning.
Okay. Very good. Okay, next question. I work in integrated behavioral health. We screen all women for depression and anxiety using the PHQ and the GAD, including pregnant and postpartum women. What are your thoughts on the effectiveness of these screens?
Oh, that's a struggle. I mean, it's important. I think that with the effectiveness, I struggle as a clinical provider because we would do the PHQ for a lot of patients and we didn't have referral resources. So the screening tools, I think, are very effective. The hard part is we have not built an infrastructure for care. We have not built an infrastructure once someone screens positive, then what is one to do? And so many of my colleagues in OBGYN are afraid to screen because now you have this positive indicator in your chart and you have no real community or no capacity to ensure that the person gets the needed services they deserve. So I don't think the tools are bad. I think that our lack of investment into mental health care services is bad.
So I'll just tack onto that. You did mention that sometimes as providers, we have that uncomfortability with screening, or we lack that confidence. Do you especially see that as a barrier to the actual screening in obstetric care?
For sure, for sure. I think we get way past ourselves, right? So we're like, I don't know what's going to happen, so we're afraid. I can tell you a great example is substance use disorder. I do a lot of work with opioid with communities who are trying to deal with the opioid crisis, and they are so afraid to actually just do the screening, and they want to just do a drug test on everybody or test the placentas. To actually have to have a conversation with a human being freaks them out. So like working through, this is not about you and your own fears around the screening, but really the patients need the ability for you to work through your biases and to ensure that they can have their substance use disorder treated, you know?
Yes, yes. And that I think is a great segue into this next question. First of all, the attendee says to thank you for your time and all your work, and then asks, do you have some suggestions when it comes to establishing trust?
Well, first, it's really looking at your own real biases. I'll give you my own. I started practicing. I have many biases, we all do, but one of mine was around HIV. When I started practicing, it was kind of the height of the HIV epidemic. And I really was being very patronizing and to patients like, oh, I don't know why a person who's HIV positive would want to, maintain a pregnancy. I would bring my own bias into how I listen to even their concerns, how I talk to them about their future fertility. That's about me, not about them, right? So like first being really honest with yourself about your own biases, because to build trust, you have to trust them. So I have to trust that if a patient who is HIV positive is asking me about future fertility, it's not my job to judge the how and the why and what their desires are. My job is to trust them and to support them in that decision making. So that's a very different orientation. I think it's hard for us because we want to still leave our biases intact and want patients just to listen to what we say. And that's not going to be bi-directional trust. That's just us wanting to tell people what to do. But for us to really build trust with patients, we have to really be honest about what our biases are and work through them.
Yes, excellent point. This attendee was wondering if you could share some thoughts about the intersection between fertility justice and mental health.
Yeah, man, this is a whole new world. I'm a fertility patient. I have a son who we used a gestational carrier with, and that journey was a lot, even as an OBGYN, and thinking about the future around mental health. I remember sitting in the room and knowing that I had become my patients. I burst out into tears and said, look at me crying in the doctor's office. My own patients. We make no room for patients to be seen, even when they have infertility journey, especially for women of color. We're not known. We're supposed to be super fertile, hyper fertile, and the truth is we're just not. So the data shows that we actually have higher rates of infertility, but that's not the ethos in the country. People believe we just have all these babies and we're doing all these things. And so our mental health about being fully seen as women tied to mothering and our fertility journey and where people are, the impact on fathering and on like partners. Fertility is equally as common. Infertility is 30% mother, 30% the male factor. Infertility. We don't have any of those kind of conversations around. It's not your fault. No blame and shame. We're all in this together. How do we then build wellness and well-being for all people? So it's deeply tied.
Do you feel that depression in pregnancy looks similar or different to postpartum depression? And as a pregnancy care provider, how do you address that?
Yeah, I would say that I worry that it heightens. I feel like I'm doing double speak, but your hormones do change after you have a baby, and that the postpartum is a moment of big hormone shift of having kind of all this progesterone and all these hormones in your body. So I do. This is anecdotal, and I don't know if there's any study around this. I do feel like it's different after that hormonal shift after you have the baby. And so preparing people for this big change in your hormones, it changes when you breastfeed, it changes when you stop. Like there's all these moments that your hormones change. And if you're not prepared, if no one's explained to you that some of your responses, your mental responses will change because of the biological things happening in your body with your hormones, then it's going to be much harder for you to navigate those changes.
So this question is asking, I think, from your perspective, do you think the greatest training needs for behavioral health providers when it comes to behavioral health, substance use disorder diagnosis, and treatment for perinatal patients? So I think they're asking, what do you think the biggest training needs are there?
Well, my work is around Black folks. So I'm going to say that we need to work on bias no matter what the things are, because it's harmful for everybody when we enter into any of those things with our own biases and our own assumptions. And so be it substance use, be it perinatal mood, be it any of those spaces, really undoing our biases and looking at the harms that we cause as providers to our patients. I mean, there's a long list in the history of psychiatry and psychology around how that has been used as a tool of harm for patients. And how do we acknowledge that history and then be truthful about what we're going to do differently is our current day when we provide care for patients.
Yes. Okay, next question. How do we get Black women more open to seeking mental health treatment?
Yeah, I mean, I think it's on us to be more open about our own selves as well. So I spend a lot of time with folks who are wanting to convince Black folks of something without being honest about why they don't come. There's not that Black people are not participating in mental health because they have some reason they're illogical in their choice. It has been used as a tool of harm. If you've gone before and a child has been taken away from a relative of yours because they even mentioned that they had some feeling of sadness, you're afraid to do that, right? So like, how do we create a community that's welcoming and that does not judge and blame and shame and police people, but actually wants to invest in their well-being? When we show that trustworthiness, then people will be more open to wanting to come. I say that to my OBGYN colleagues. If you ask birthing people, they don't want to go to OB. They want to have a baby in a birth center. So if instead of us saying, why don't they trust us? We have to build a community that's trustworthy.
This person thanks you very much for your training and says that you had mentioned that the NBEC provides a 4-hour training. Do you post more information about your 4-hour training on your website?
We are revamping our website right now. Okay. So I'm not sure what it says on there right now. But yes, we have a 4-hour and an 8-hour because sometimes it depends on the people, right? Like folks want to have 4 hours where they learn and then go home and sleep on it and then come back and do some more work 4 hours. So we have a whole training curriculum really working on this respectful maternity care. We have been doing it for a long time, for 6 years, working with health systems, with hospitals, with public health departments, with large nonprofits, like, March of Dimes or whomever. And so this opportunity to really rethink about what we all need to unlearn and what we need to learn together is important.
Okay. So here's a question on terminology.
Okay.
Why don't we use peripartum instead of perinatal terminology? Would that not help us in shifting the emphasis from the candy to the wrapper?
I like it. Listen, language is constantly changing. You see, I'm trying to work on my language. I am not the best. I really feel like there's a lot for us all to learn when it comes to language. Language is so important. And I think we can definitely move it. I mean, I spend a lot of time talking about pregnancy intention. I don't know if you heard me talking about that, but pregnancy intention versus pregnancy well-being. And so that's a new term that we're trying to socialize. And it requires also us working with folks like you all, because well-being is mental well-being. Well-being is also access to food and all these other things. But really, how do we ensure that the language matches what we actually want for people?
Yes, and being open to those suggestions for the shift, for sure.
Okay.
So here's an interesting question regarding perinatal loss. How would you suggest going about increasing direct access to mental health care in the hospital after a perinatal loss? This person says it seems hard to get access directly to patients because of hospital bureaucracy, and patients might feel very unsupported at that time.
It's a weird moment. I used to tell people that in Louisiana, we had a law that you had to bury your baby if you had a perinatal loss, right? But we didn't have a law that said we had to provide you with social support if you had a loss. So we come up with things that you must do, but we don't come up with things that we must do as a system. So yes, right now, all we do as providers is consult social work. So that's one thing in the EMR, and a social work person will come and say, oh, there was a loss. We consult grievance services, but all this is so not continuous. It's not a real system. And that's something we're going to have to build together with you all.
It looks like we have just maybe time for one or two more questions. Are there any other resources or databases to help birthing people, especially birthing people of color, to find medical providers and OBs of color?
Yeah, there's like blackdoctor.org. There's also a doula, a listserv for doulas that I'm blanking on the name of right now. On the Black Mamas Matter Alliance website, we have some resources, not necessarily a directory, but some resources of places that you can go and look. It is hard because we want people to find providers who are culturally congruent, and that's not always easy. And so we want you still to get care. And so making sure that people have access to both.
Yeah, and finding that good fit. You got to feel
Mhm.
comfortable with those
Yeah.
questions.
Yeah. Oh,
Do
yeah.
you
Someone
have,
in the chat wrote Earth is a great example. Kimberly Seals Dollars. Yes. Thank you.
so I think we have one last question here, and this is very interesting as well. Do you
Mhm.
have any thoughts about depression screening at child well visits, as they are more frequent than the 1 6-week postpartum visit that we often get?
For sure. I think there's been a move to try to get pediatricians to give more of these kinds of things, because women are more likely, or birthing people are more likely to go to that pediatric visit than to go to their own provider. And so I want a reimagining of both. Like, yes, we do need to ensure that pediatricians are able to give the screenings and the other things that people are missing, but we have to reimagine why people don't want to come back to see us. What are we doing that's a barrier that makes them only care for their baby to go to the pediatrician, but they don't want to, we're not making a welcoming space for them to want to come see us.
And would you agree that once we do see them back for that annual well woman exam and such as well, we have an obligation to even talk about mental health a year
All the
later?
time. Yeah, it's just not a part of, when I tell you it's a gap in our training for obstetrics and gynecology, it's a huge gap that I think people are trying to address. But I also want to say that I don't think our role is to become to be, I think there's a bunch of you. So our role is to understand it enough so we can do correct referrals. We can do correct, like that's, I think we get lost in, oh, that's so much, but it's not really, we need to know enough of it so we know the correct referral and the correct time to ensure that people have all the resources that they need, not that we're going to be the source of care.
Well stated. It's that interprofessional collaboration
Exactly.
that we have. Very much so. Thank you.
Thank
All right.
you.
I thank you so much. I think at this time, Marianella, if we could advance to the next slide. We just wanted, as we're winding down today, we just wanted to remind you that we have a new perinatal mental health website, and we have a lot of excellent resources on there, and we encourage you to visit this site. Our presentation today with our slides and recording will also be available at this site. Next slide. We would like to encourage you to attend our next session as well. That will be held on May 19th. And at that time, we're going to talk a little bit more about treatment with perinatal mental health conditions. And then next slide. And then lastly, today, we would ask that you would please take a moment to complete a brief survey about today's session. Your feedback is very important to us, and you will be directed to the survey when you close the Zoom platform. So next slide. And that will take us to the end of our session today. So please do fill out the survey, and we welcome any of your feedback. And we just thank you all so very much for attending and hope you have a great day.
Thank y'all. This is fun. Bye.